Hello and welcome to today's latest live lunchtime learning session. Today we're going to be talking about our Complementary Rehab Assessment service. It's both terrific and terrifying that so many of you have joined us today, but it's wonderful that there's such an appetite to learn more about this key early clinical intervention that we provide. So the purpose of today's webinar is to outline the Complementary Rehab Assessment service so that you're more aware, or maybe being made aware of it for the first time, that you leave more informed and you can understand how it can benefit both you and your clients, which is who we're working for essentially. The session is scheduled to last around 45 minutes. Hopefully you can keep to time. It should be fine. As an introduction, my name is Scott Richardson. I'm the Business Development Manager here at Dorset Orthopaedic, and I look after the CRA inquiries predominantly for the Amersham Clinic, but also for the Egham Clinic. I'll be talking you through the referral process of the CRA and how that works before handing over to my colleague, Connor Murray, who's joined me today. Connor is a clinical lead physiotherapist at Ringwood Clinic, and it's fantastic that he's able to join us today to give a clinician's point of view regarding the CRAs. After Connor's session, we're going to be joined by Christine Sharp, who's a case manager from Integrated Case Management, and her client, stroke our patient, called Jack, and they'll be giving their perspective from a case manager and from a patient's point of view. Once those sessions are done, I'm sure there'll be questions stimulated as part of the discussions. Feel free to put them up on the system using the Q&A functionality on there. And in the final session, Connor's going to take us through those questions that we've had before we close up for the day. In terms of interactions, I say use the Q&A session, and we'll endeavour to get to those questions as we go as we get to the last session. So essentially, what is a complementary rehab assessment? First of all, it's a free of charge clinical assessment, and it's carried out by our interdisciplinary team or multidisciplinary team. And it's designed for individuals who have either sustained serious limb injury or limb loss and are going through a litigation claim. For clarity, it's not to obtain costs for quantum purposes. It doesn't fall, and it falls outside of any medical, legal, or expert witness aspects of a claim. Essentially, it's a no barriers way to obtain a clear treatment plan with detailed costed recommendations with the intention of clinical activity to follow after the assessment. So generally, liability would have been established, and the client is in a position to move forward and embark on the rehabilitation pathway. And I think everyone will unanimously agree that the sooner we can start rehabilitation, or the sooner that can begin, the better the outcomes are going to be for the patient, and hopefully in the most cost-effective way as well. We accept instruction from any of the key stakeholders involved in the litigation process. So that can be from a claimant solicitor, a defendant solicitor, an insurer, or most commonly from a case manager. And we're delighted to have so many case managers joining us today. They can be singly or joint instructed. It makes no difference to us. The assessment we carry out and the report is the same regardless. Really, the assessment, and hopefully Jack will testify to this a bit later, the assessment is a good opportunity for the patient to meet the team, to see the surroundings, see what facilities we have, what we can offer, to see if he's for us and we're for him equally, because committing to rehabilitation is vital, and there's almost certainly going to be a whole host of appointments required, particularly in the early days, in those initial stages. And so it's important that everyone gets on and feels comfortable as they're going to be working closely together over the coming months, if not years. I'll move on to the presentation now and talk about the process, how it works. So thanks to merger just over 2 years ago now between Pace Rehabilitation and Dorset Orthopaedic, and the subsequent establishment of some satellite clinics, we've now got an unrivaled nationwide choice of locations for patients to choose where to have their clinical assessments. But step one is to reach out and contact us, and that can be done by email. There's online forms on the website. to do that, or simply pick up the phone to have a conversation with us, and we can triage and make sure that the services we can offer are appropriate and timely for the patient. Generally, I think it's fair to say geography dictates the patient's choice of clinic, and with a huge choice of places that we have, hopefully they won't have to travel too far for that treatment or for the assessment. But once we've established the location the patient wants to go to, a member of the team who looks after those inquiries at that clinic will be in contact. They'll be on hand to make the necessary arrangements, get the right paperwork in place, and arrange a mutually convenient assessment appointment. Now, we want to try and avoid reporting information that's already been recorded. So if you're a case manager and you have your own immediate needs assessment report, and that's a shareable document, that is absolute gold dust to our clinicians. They really welcome having sight of that beforehand. It saves us going over old ground and asking the client questions which they've answered previously before. Also, if you've got any medical records or medical reports that would be useful for the clinicians to have sight of before the assessment, that's absolutely welcomed as well. As Connor will outline in a moment, we're really focusing on moving forward the immediate future rather than dwelling on the past. It's all about those steps going forward now. So there'll be a lot of information. So if you're a case manager and you're able to get permission to attend the assessment, approval to attend the assessment, that is fantastic, because there's, I say, a lot of information being imparted back and forth. To try and digest that and remember all that is a challenge. So there'll be a lot of terminology as well. So it's really useful if we can have the case manager in the room at the same time. That can happen virtually, ideally in person, but we can do it virtually if needs be, just to make sure everyone's hearing that same information. So once the appointment is arranged and the client comes in, hopefully with a case manager, it's going to be with two clinicians. Now, it's always with a physiotherapist. If we're talking about a loss of function to a limb, foot drop, etc., then we will involve an orthotist. But if it's about limb loss, then we're going to have a prosthetist. There are some instances where we have all three clinicians, if that's a requirement, maybe amputation on one side and loss of function on the other. But generally, it's the two clinicians. It's a free of charge assessment. It's the opportunity to understand the patient and to determine what is most appropriate for that individual. All the clinicians are very experienced and have decades of knowledge, but we never really know until we start working with a patient how well they're going to progress. And sometimes patients do better than we anticipate, and sometimes they maybe take a slightly alternative or longer route to achieve their goals. We don't really know that at the time of that initial assessment. That sort of comes out with experience of working with the patient. So you may see changes to the prescriptions and the recommendations that were initially made in the CRA, but with our clinicians keeping you informed throughout the process, hopefully there won't be any surprises there. Now, as we'll all appreciate, none of the kit we ever talk about is cheap, be that prosthetics or orthotics or the therapy services. So it's really important that what we recommend and provide is appropriate. Therefore, you might see trials mentioned in the report, which can be very important. We'll talk about that in a bit more detail a bit later on. So hopefully that explains the process of the referral and how we process those instructions that come through, and to the point where the patient is coming in for their assessment. I'm going to hand over to Connor in a moment, who will talk about it from a clinician's point of view.
Thanks, Scott, and thanks everybody for joining this session today. So yeah, I'm going to talk about the CRA from a clinician's perspective, and I'm going to break it down into four main points, really. So we'll talk about the aims of the CRA in detail. Scott's gone over a few of them. I'm going to talk about what the assessment itself actually contains. We'll talk about the clinical prescription, so be that prosthetic, complementary and orthotic device and rehabilitation. And then we'll talk about the clinical reasoning that we employ, not just during that assessment, but throughout the patient's treatment journey, to make sure that that prescription remains accurate for the patient at all times. So what are the aims of the CRA? So ultimately, we're trying to gain an accurate clinical picture of that individual patient. We want to understand that patient themselves. What are their aims and what are their goals? What are we trying to support them back to? What's quite important as well is we want to just introduce the patient to the local team and the clinical environment. We know the assessment's important from our point of view to get a clinical picture of that patient and understand what we want to prescribe. We know the assessment's important from the legal team's perspective to get accurate costings, but it's really important for that patient as well, just to feel at ease with the clinical environment, feel at ease with the team, and feel happy about attending that clinic for treatment. We can answer any questions that the patient may have about their future care. We know that the rehabilitation journey after significant traumatic injuries can be lengthy, and it can be daunting for patients. So it's good to settle any concerns that they may have at this stage. And as Scott mentioned, the report that we provide should provide a bespoke treatment plan and provide accurate costings for the legal team. So ultimately, we're trying to provide a clinical picture of what that patient's immediate treatment needs are at that point in time. So of course, these needs can change over time. And we'll endeavour to update both the patient and their legal team if we consider alternative options to be appropriate. This may be as a result of a physical change to the patient. So, for example, they may need to return for further surgery, or it may be as a result of new assistive technologies being added to the market. So this assessment should therefore be considered as a reflection of that patient's current physical status at that point in time. And the most important aspect of all of this really is that we're trying to facilitate the start of the patient's treatment as soon as possible. Why are we trying to do that? Because we're trying to reduce the complications that can arise from delayed intervention. So I can't see any of you, but just to make sure you're all awake, it would be nice if we could get some answers to this question here. So what complications do we think can arise from delayed intervention for prosthetic and orthotic patients and their rehab? So you can pop any answers that you may have in the Q&A section on the right-hand side. Hopefully we get some, otherwise I'll just carry on. Anyone have any ideas? Can be any complication at all, physical, psychological. Low confidence, Stuart? Yep, thanks very much. Perfect. Lack of ability to carry out day-to-day tasks? Yep, definitely. Psychological trauma? Absolutely. Anyone have any more physical ones? Any thoughts? Yep, absolutely. Compensation injury, so injury somewhere else in the body through a biomechanical compensation, absolutely. Limited range of movement, yes. Unhelpful movement patterns, yep. Changes in gait pattern, absolutely. Lovely. Okay, well, we'll move on to the next slide. Increased pain, Louise. Perfect. Thank you very much. So hopefully that's just shown that the delay in intervention can result in widespread issues for our patients. So it's really essential that we get them in for us for assessment and early treatment as soon as we possibly can. So physical risks that are quite common are muscle atrophy. So reduction in size of the muscle fibers themselves, and as a result, a reduction in strength. So we know that this can occur after just 7 days of inability. And if we think of that patient's journey after a traumatic accident to physically getting into the clinic, we know we're talking about lengthy timeframes. They can have significant hospital admissions of several months. We know that they can be waiting around at home, wheelchair bound for a significant period of time. And as a result, their risk of presenting to clinic with a significant deterioration is likely. Joint contractures, as we mentioned, are likely. Specifically, we're talking about the risk of hip and knee flexion contractures for our lower limb amputee patients if they're spending a significant period of time wheelchair bound. And whilst these can be accommodated for to a degree with prosthetic alignment, we need to ensure that we're maintaining as functional a range of movement as possible. Falls is obviously a big physical risk factor. So patients may have impaired mobility prior to orthotic fitting, or maybe solely wheelchair bound whilst waiting for prosthetic fitting. And these can both provide significant risks to falling. And we know that any injuries that are sustained through a fall in this early acute phase can potentially impair their ability to engage with rehab. And it could also raise the risk of opening up any surgical wounds, which could delay prosthetic fitting. Psychological risks, there were a couple of answers for on the last slide. So body image is quite a big one. So we know that there's lots of research now coming out that delayed prosthetic fitting can have a negative impact on the patient's body image and reduce their quality of life. So just showing us how essential it is to get these patients in and limb fitted as quickly as possible. We know that the loss of independence and impaired function can negatively affect the patient's mood. And we know that if patients are arriving with low mood, this can negatively affect their motivation to engage in rehabilitation. So it's, there's a full kind of circle of symptoms that patients can present with if they're not treated early enough. From a social perspective, we know that the impaired mobility can reduce independence. And as a result, this can put stress on the patient's family or carer. So we need to nullify that risk as best we can. And then from a clinical perspective, so I touched on it briefly, patients that are significantly deconditioned, significantly weak, and arrive with joint contractures are harder to successfully fit from a prosthetic and orthotic point of view, and they increase the complexity of the rehab process. So the longer the wait in getting these patients into us, the more complex and potentially the lengthier their rehab journey may be. So just thinking about the assessment itself now, we're just going to break it down into different components to give you an understanding of what's actually contained within it. So the history of presenting condition, hopefully we'll have received a lot of information from yourselves about the patient. It's not always the case, but it's really useful to have those INA reports just to give us a full picture of what that patient's experienced before coming through the clinic room doors. We know that legal patients have to attend lots of different appointments, and sometimes it can feel like they're repeating this information to lots of different clinicians. So if we can reduce the amount of repeated questions that we're asking the patient, the better. We'll talk to them about their treatment history so far, so whether they've had any orthotic or prosthetic provision from the NHS or another private provider, and what their experience of that and their rehab has been. Anything that did or didn't work for them, anything that we need to either replicate or avoid. We'll talk to them about their past medical history. Again, hopefully we've received a lot of this information from the referrers. Are there any factors that we need to consider in the patient's history in regards to previous injuries, limitations, or health conditions that could affect their rehab? Social history is a really important one, so we'll dive quite deeply into this. It's really essential for us to understand who this patient was prior to the index event. What was normal for them? What was work like for them? What was their family life? What are their hobbies? What interests do they have? What was their mobility like beforehand? Just to give us a clear clinical picture of who this patient was, what do we want to get them back to doing, and have a kind of in-depth understanding of what their baseline was. Pain is a big one. We've kind of discussed that already. So what has that patient's pain journey been like following the index event? What analgesias are they currently taking? Do we feel that this is optimized? Are they getting any side effects from this analgesia? Is it affecting their sleep and therefore their mood and therefore their energy levels in order to engage with the rehab? Do we feel their pain levels are currently managed to the point where orthotic or prosthetic fitting is appropriate? And is it appropriate for them to start their physical rehab journey, or do we need to look at a pain management program first? And have they tried any other pain management strategies away from kind of routine analgesia? So moving on to our objective assessment. I've missed a couple of points there. So two big ones really. Goal setting, as I've kind of spoken about. Social history is really important. Trying to understand what that patient's ultimate goal is. What would we like to get them back to doing in the short term? What do they think life's going to be like for them in the years to come? Just to give us an accurate understanding of what their needs are and how we can adequately provide and prescribe rehab and componentry in order to help them achieve those goals. We'll also include a psychological screening at this point, so we complete a short outcome measure to aid with identifying any patients that may require any psychological support or counselling, and we can signpost them to adequate services at this stage. So moving through to the objective assessment. So we'll complete a full musculoskeletal screening at this stage. So this is a review of the whole body, not necessarily just the injured site. How do they currently move? How functional are they? And what are their physical limitations? What may require treatment outside of the limb that requires prosthetic and orthotic fitting? So thinking of that patient as a whole. Are they strong enough to stand and mobilize? Or what do we need to do in order to get them to this stage? We'll review their current prosthesis or orthosis if they have one. Are they finding it comfortable? Is there anything they do or don't like about it? Are there any concerns about skin integrity or any areas that we may need to accommodate for? We'll do a full functional assessment. So what can that patient currently do? How are they transferring? How are they walking? How independent are they at the moment? Have they started to re-engage in any hobbies that they previously enjoyed? And are they looking at getting back into work and reintegrating into society? We'll do a thorough gait analysis, if possible. So for a primary amputee, if they have a NHS prosthesis, we'll review their walking pattern on this. For orthotic patients, if they have an NHS device, we'll review with this or without altogether if they don't have one. And do we feel like any abnormalities in their gait are being caused by their current provision? So can this be improved through improved prosthetic componentry or alignment or a different orthosis? Or do we feel like these abnormalities are caused by a restriction in joint movement or generalized weakness and deconditioning? So is it something that we can improve with rehabilitation, prosthetics or orthotics, or is it all three? We may take outcome measures at this point as well. So this could include confidence scores or timed walking tests. And that's just to give us a baseline measure of where this patient is at this point in time and something for us to refer back to during their rehab as they progress. So talking a little bit about prescription. So I think this quote from Donaghy is quite nice from a study back in 2020. A team-based assessment leading to prescription is an effective means by which to leverage a broad range of knowledge and expertise to best ensure successful patient outcomes. And that is exactly what we're trying to do here. So we've got this three-pronged approach. We've got the patient's values in the middle, which we know are super important in order to guide us. We've got our clinical team's expert judgment, and we've got the external evidence available to us. So be that scientific evidence or information on new prosthetic componentry on the market. And we're using all three of those aspects to provide a bespoke treatment plan for that patient. So moving through to clinical reasoning. So we can see that that three-pronged process is still there with this model. So we've still got the patient's perspective and the patient's goals. We've still got the best available scientific evidence and information on componentry at the top. And we've still got the clinical judgment from our clinicians. But within that, we've got this nice circular motion happening in this model to show that clinical reasoning is a constant process that adapts to any changes. So we have the examination, evaluation, and plan of care, which will occur during the CRA itself. But we've also got the intervention that we can provide and constant reassessment. So we're constantly reviewing and reassessing these patients to ensure that the prescription remains the most appropriate for them. And if there are any changes, we can adapt accordingly, making sure that we keep the legal team involved with any justification for our changes in plan as we move through their rehab journey. So I hope that brief outline of a clinician's perspective to the CRA process has been useful. And I'll be back to answer any questions towards the end. Thank you very much.
Thank you, Connor. That's really insightful. I think it kind of highlights that in only not a 90-minute assessment that a lot of information is gathered to make sure we make the right recommendations in our reports. So Connor will be joining us in a little while to run the question and answer session. But next up will be a case manager and patient's perspective. Thank you. Welcome back. Hope that was a good break for you. I'm delighted to be joined by Christine and Jack. I think we'll open up, first of all, Christine, by explaining how and why did the pair of you come to Dorset Orthopaedic for a CRA in the first place?
Jack was injured in January 2024, and he had a significant vascular injury on his right leg, as you can probably tell. When I first saw him, he was 8 months post-injury. He had lots of problems with moving, lots of problems with his gait, and a lot of problems with pain, wasn't it? And from the start, he'd been seeing different statutory services that were sort of uncoordinated, and there were some delays with that. So what I wanted from the CRA was a timely and coordinated package of care, and with recommendations that I could take back to the parties to agree the microphone.
The microphone. Oh, yeah. Okay, so let's check. Do we have another microphone we can bring in, or is maybe something here?
Yeah.
Okay.
Yep. Is
Okay.
that better? Thank you. Sorry.
You hear that? Okay.
So basically, just a specialised treatment plan.
No problem at all. So, as a case manager who's utilised the CRA offerings previously, what would you say the key benefits are of it?
Mainly that it provides a clear and concise recommendation and treatment plans. With it, from a case manager's point of view, it really outlines what treatments are available and what those costs are. And this is particularly helpful when the funds are limited. For example, with the clinical negligence cases where you've got limited amounts of funds to use. And I think a lot of the defendant parties really appreciate the level of justification and explanation as to what exactly is going to happen as well.
Okay, like transparency, really.
Yeah.
In terms of the referral process, did you find it was straightforward, and were appointments offered in a timely fashion?
Definitely. So from my perspective, appointments usually contact within a couple of days where appointments are arranged, and often keep in contact with what process the report is, and when I'll receive that report, so I can kind of feedback and know when everything's happening.
Good,
So,
open comms.
yeah.
Jack, if I come to you, during the assessment, did you feel that you were at the centre of the process?
Yeah, absolutely. What I loved about it was just really clear, really obvious. Spoke to a couple of different people, obviously, while I was there, and they just explained everything nice and clear and made it really easy.
Sure. And I think, sport is of interest you, leisure activities, was that sort of thing covered?
Yeah, absolutely.
So it's gone beyond just, the initial treatment, it's looking more wide-ranging.
Yeah, it was coming up with a plan of what I could kind of do to get back to the level of sport I was doing before the accident. So it was really, really useful and really interesting.
Excellent. I should add that Jack has just joined us for a badminton session with one of our therapies about 10 minutes ago. So that's excellent. In your case, it went beyond orthotic provision in terms of the recommendations. There was pain management that was discussed and reported on. Did you both feel that it was a thorough assessment?
From my perspective, definitely, and Lauren was available to sort of provide not only the therapeutical advice, but to give me advice on when to get medics involved as well, and if medic involvement was needed. Okay.
And Jack, I think that you maybe didn't realise, but the recommendations for interventions on your other foot as well, just wasn't on the one side.
Yeah, no, it covered everything the whole way through. It was really interesting.
So when we provide the report and the cost of recommendations, we try and do that within a few days. Sometimes it can take longer if we're waiting for feedback from some of the manufacturers in terms of availability and costings, etc. But once you've got the report, was there much need for follow-up, or was everything covered in the report so you could go to the funders with that information, and how did they receive that?
Funders usually receive it extremely well, and I think I don't usually come back with questions. The important thing is that you provide a itemised invoice, and it will go through exactly how many hours, how many sessions, what the equipment is that's required as well. So, and the breakdown of the all clinician time, which is really helpful.
Yeah.
And as you said, transparent.
I think sometimes we'll put in a block of physiotherapy, and it will say X amount of hours, and they can be quite significant numbers. Is that useful to you if there's a bit more of a breakdown? Obviously, sometimes it's difficult to predict that.
As a clinician myself, I understand that the physios won't be able to tell you exactly what they're doing in each session. I understand and appreciate that the clinicians that you have here are highly specialist, so they will know from their own clinical backgrounds what's going to be needed for what client as well. So just relying on their expertise, really.
And just to highlight, that goes beyond just being in the clinic room, doesn't it? It goes out to leisure
Get
centres, get out about shopping, whatever. Did you feel that the recommendations that were contained in the report are reasonable and appropriate?
Definitely, and I think part of it is not only just looking at the physical limb, but also including daily activities as well. And Jack really enjoys sport, so I think you've had specific kickboxing sessions when you're here as well. It's one of the things that you really enjoyed beforehand. So I think that's really important for the patient, getting them back to that place where they would have been but for the injuries as well.
Would you say it's very much a can-do approach we're taking here with you?
Yeah, absolutely. It was from the start. We just started moving, and they adjusted their original plan bit by bit as I got better at it and started doing more activities that I used to do. As I said, the kickboxing was one of the guys here happens to have been an instructor, so that was really helpful. So yeah, we kind of filled it full of things that were interesting and exciting and just fun.
Yeah, if rehab's fun, it doesn't seem like a chore.
Exactly.
In the prosthetic cases, we make recommendations for an ADL, an activity of daily living prosthesis, or everyday prosthesis, but I guess sometimes it's useful to have references to subsequent devices as well, and transparency about those potential costs in the report.
Definitely, particularly like Jack was saying, is that sometimes changes as the rehab progresses, and I think the clear communication from Dorset is really helpful for me to go back to the funders to actually explain why there might be a change in the costs and why is it happening, and being able to provide the feedback to why he's progressing fast or why he's not progressing so fast.
That's going to be my next point. So, once clinical activity commences, there may be changes to the recommendations, sometimes the cost, but hopefully not too much. Do you find that problematic for the funders?
Not really, because I think Dorset provides a lot of justification and reason why they're doing it, and they're quite clear with what they're doing and why. So the transparency's there.
So being kept informed all the way along.
That's really helpful.
Okay. Next point is, there's an ever-increasing choice of prosthetic and orthotic solutions. Trials may be recommended to confirm what's appropriate and what isn't appropriate as well. Do you think it's reasonable to take for these for such recommendations, and do you think that the funders welcome this approach and this information?
Yeah, definitely. And in my experience, sometimes what may look good in an initial assessment and on paper, when the clients are actually out trying them on the day-to-day things, doing their shopping, doing whatever they do on a day-to-day basis, it may not be the appropriate one. So I think trials are hugely beneficial for the equipment, given the costs of some of the prosthetic equipment that you are recommending, and that are best for the clients in every aspect of their life as well.
Yeah, I always say we'll pay insurance premiums ourselves. We don't want them to go too high. In terms of what would you say the benefits are of having that interdisciplinary team approach as part of the assessment and the treatment plan?
I think it's really important, particularly when you can look at lots of different things as well. So not only just the physical rehabilitation, and I think in Jack's case, it's been really beneficial to do the pain management course with Lauren, because, that was one of the bigger issues, wasn't it? And running that alongside the physical rehabilitation has been really helpful. I think you'll only get that when you've got your specialist clinicians.
Yeah, I think the thing you kind of really pay for in the private sector is the ability to respond to changes. When things need adjusting, or you're taking a different route. The best will in the world, statutory services. You can be working weeks, if not months, for appointments. It's that one-to-one service. I think it's beneficial. Just a closing question, really, for you, Christine. What would you say the overriding benefit is of instructing a CRA?
I think it's mainly just having the exact prescription there in front of you, having the exact justifications for why, and actually knowing in advance what's actually going to happen. And with the case management, with the pain management, there's decision timings for it as well. So being able to know what's happening when is really beneficial as well.
Lovely, that's great. Thank you very much for both your input. That's really useful. We're going to finish off in a moment with some questions. Use the evaluation form as well to ask your questions. That'll be coming up a bit later. But for the time being, thank you very much, Christine, and to Jack. Thank you.
Thank you.
Thanks, everyone. So we're just going to run through some of the questions that you've left for us now, so if we get those up on the screen. So are waiting times for CRA reports the same across all clinics? Scott, do you want to take this one?
Yeah, I mean, it depends on clinicians' availability. We'll see how busy they are. We'll absolutely endeavour to get the patient in as soon as possible, but it needs to be the right people. Sometimes we do a bit of marrying up to get a little bit of background about an individual, their gender, their interests, etc. Sometimes we might think that has a better fit with one clinician over another. But on the whole, we're trying to provide an appointment, I would say, within weeks rather than months. And it's about managing that expectation of the patient. Once then funding, the receiver report and funding is in place, we want to start as soon as possible as well. So it's all about maintaining that momentum. Sometimes you can maybe start too quickly, and then there's a little bit of delay in treatment, and that's not ideal. So it's all about getting the pace right, I think.
Absolutely.
So we talked a little bit about the limb trauma, the CRA, and that's for patients where the presentation is maybe slightly less challenging or complex. For those cases where a patient is maybe considering limb salvage and or even elective amputation, then we have a limb trauma clinic service that happens on a monthly basis. It's outside of the CRA, but that's run at the various clinics around the country and is led by a consultant in rehabilitation medicine, and that's Dr. Rodri Phillip, who some of you may know, and he came from the Headley Court, lots and lots of experience, fantastic consultant. He'll cover the medical aspects of a patient in terms of the medication, and maybe referring on to plastics experts, etc. But really giving the patient a lot more information about their decision whether to go down a limb salvage route or amputation. Sometimes one can lead to another. That time isn't wasted if you do go down limb salvage and you maybe have an orthotic intervention that's going to be like an offloading brace, and then amputation subsequently occurs. That's not a drama. At least a person will be in better shape for that rehabilitation. But that's just another service that we can offer. It is chargeable. It's outside of the CRA, but is another service that's maybe of interest to you. We have a web page about that on the website.
So Jack, there's a question for you here. What kind of pain management strategies have you tried, and what works for you?
So I mean, a lot of the pain management was just mostly getting it right in your head, I think, basically. That was the big thing. I was on a lot of medication to start with, so I spent a lot of time with Lauren. It was kind of adjusting between the physio side and the pain management side was really good, because it just meant we kind of try the bits we talked about in the theory of pain management, actually doing it. They did some muscle stimulation, a load of massaging, even a bit of acupuncture. But yeah, so there's loads of different ways they kind of worked on it, and it really helped get off the medication, so it's great.
Brilliant. So were you getting some side effects to the medication at the beginning?
Not particularly that I noticed. I think there was, probably I was a bit slower thinking about everything and kind of getting things together in my head.
Sure.
But yeah, that was kind of it. But yeah, it was a lot of quite heavy medication early on. Yeah. So getting off that was just one of the goals I had early.
And did you take any of those strategies that Lauren kind of taught you? Are you doing them in your own time now? Yeah,
absolutely. Just thinking positively about it, going through the kind of, the mental side of it, knowing the difference between pain because it actually hurts and pain because you think it should hurt, and that kind of side of things was really useful, really interesting, and covered pretty much everything. So I use that all the time.
I think it's fair to say that pain can really derail all the best intentions of the clinician kind of and clinical activity. So if we get on top of that, that's hugely beneficial. We have a question here from Sarah Mills.
So are there limitations as to what can be carried out at the satellite clinic sites? So yeah, that's a great question, Sarah. So the satellite CRAs can be completed at all the satellite clinic sites. So the clinicians can attend those sites in order to complete the assessments. That's not an issue. Patients can also attend for a kind of routine review of prosthetic or orthotic devices. But we're not conducting any of the rehabilitation currently at the satellite clinic, so they still have to travel into our standard Dorset sites to attend any physiotherapy appointments and any kind of larger work where the prosthesis needs to return or the device needs to return to workshop. The device, the patient could travel in to drop off the device at the satellite clinic if it's a shorter journey, but the work would still need to be conducted potentially still need to be conducted at one of our main sites.
Yeah, the main difference is we don't do manufacture on site at the satellite clinic. So we might have heat guns to maybe do some small adjustments or to swap out on servicing tools, that kind of thing. But we don't do manufacture. So I think it's probably reasonable to say if for transfemoral prosthetic provision from casting through to delivery, say there was 12 appointments, it might be that 4 or 5 of those could happen locally at a satellite clinic, but there would still be a requirement to come into clinic for having the facilities to make the adjustments and having the workshop on site. That's the biggest difference. But it just takes some of that pain away of the travel that can be required. I say, is there any questions? That's the question.
One's just come through here. So how do you decide how much rehab someone will need? So that's back to our kind of clinical reasoning and the whole point in the assessment process. It's understanding who that patient is, what their physical limitations may or may not be, and what it is that they're trying to get back to doing. And we're taking multiple factors into consideration here. Their age, the extent of their injuries, the level of amputation, the componentry that's been prescribed. So there's lots of factors at play. It's not a kind of copy-paste treatment plan. Every plan that we send through should be bespoke. So there's multiple different factors, but the MDT is really useful in that to kind of get to grips with the answer of that. Yes, I'm looking at prescribing how much rehab someone will need, but I'll also be talking with the prosthetist or orthotist about what we may or may not feel is the correct componentry for them, and equally they'll be suggesting to me what they feel the patient may need from a rehab point of view. So there's constant discussion between all of the clinicians. And if we think back to that kind of 3-pronged approach that we're talking about, one of those prongs was clinical expertise. And what we're really lucky to have at Dorset Orthopaedic now, especially since the merger, is a large network of clinicians that have got extensive experience. So if we have got a particularly complex patient who we may not have maybe seen that condition much ourselves, or they've got lots of other things going on, we've got this network. If we don't have the answer straight away, the likelihood is there's somebody within the organisation that has got the answers, and we can discuss that with them.
Okay. Chloe, if you could just put up on the screen here, we've got a case study here. This is, I like to entitle it when the stars align. So this is an example of a client up in Glasgow who sustained a road traffic accident and spent about 18 months trying to salvage his limb, and got to a point where he decided, the guy's in his 80s, the clock was ticking, he decided to go under, have an elective amputation. And so case manager reached out to us, obviously on the 7th of June, to inquire about a complementary rehab assessment. Soon after, the patient was discharged from hospital, and so we carried out the assessment actually at the clinician's home, the patient's home near Glasgow, and that was with a prosthetist and physiotherapist. And off the back of that, they provided the costing recommendations. This instruction actually came through from an insurer, and we provided the report, you see on the 2nd of July there. Within a week, funding approval was provided. This included a trial as well. Everything was rubber stamped or green lighted to proceed, and we were able to start that clinical activity almost straight away. So we took the cast of the patient on the 15th of July, I think that's it, so that's 16th, I've got my glasses. And then within 2 weeks, he was up standing on his prosthesis, receiving physiotherapy treatment. That, it doesn't get any better than that, and we appreciate there are going to be bumps in the road and delays in funding, etc. But when everything works properly and everyone pulls in the same direction, this is something that can be achieved. and the patient doesn't have time to become deconditioned. We can get working with the patient straight away. That was a good example to have up there. So if you like what you've heard today and want to hear in more detail on some of our other services, we do have our annual conference coming up on the 19th and 20th of June. This year it's in Nottingham, entitled Rising to the Challenge. Following the format of the last couple of years, people arrive on the Thursday evening beforehand, and we have a guest speaker in Alex Lewis. Some of you may know Alex Lewis, an incredible guy, so inspirational. Lost all 4 limbs through sepsis several years ago, but certainly hasn't held him back. There's a QR code on the screen there you can scan in. Already there's over 100 people enrolled for it, and there's a few more places left. If you're interested, get yourselves booked on there, and you'll find out more information about our clinical services, patient account stories, latest technologies, those kinds of things. It's a full pack day on the second day. Hotel accommodation is included in the price. What a bargain that is. So additional to that, we have open mornings. We hold these around our clinics around the country. There's normally 2 in each clinic around the countryside. The next one is in Burton-on-Trent on the 23rd of April. All this information will be put in the summary that you'll get after the recording's finished. The second one after that is in 20th of May in Egham, and then the third one on the 11th of June in Manchester, and it rotates on. For some patients, osseointegration, we've talked about prosthetic provision and sockets, etc. So for some patients, osseointegration is of interest to them and something they'd like to find out a bit more information about. So we do hold osseointegration taster days. That's with the team from Reading, Norbert King and Alex Willard. This is another free service for patients to come and just find out a bit more about the osseointegration process, the medical side of things, and see if it's for them. If they do decide it's something they want to explore, then a full clinical assessment can happen down at the Royal Free Hospital. This is like an information day about that. The next one is coming up very soon on the 4th of June in Amersham, followed by Manchester in September and Ringwood in December. So that might be of interest to some of you. Thank you to everyone joining us today. I hope you found the session useful and you've learnt more about our clinical offerings. Be delighted to see you at the conference. You'll get a recording of today's session. That will be sent back to you with an opportunity to provide your feedback in your comments. But in summary, I think generally it's never too early to make that inquiry to us to discuss the clinical offerings that we can provide to help your patients. The sooner we can get that patient onto their rehabilitation pathway, the better for everyone, but most important for the patient. So thank you very much for joining us today. Have a good afternoon and enjoy the rest of your week. Thank you.